no financial disclosures. This is the outline of my presentation. So I begin with the difficult task to guide you step by step through fetal echocardiography in 25 minutes. So let's try. I'm going to base, so most of my talk is based in both of the international guidelines. So the reason of having guidelines is because of the huge variability between hospital centers. Okay, let's try. Yeah, so I was saying the reason for the international guidelines is because there is a huge variability in between centers, hospitals, different countries, and even in the same country in different regions. So in the UK, for example, we have, in some areas, there is less than 40% of prenatal detection, whereas if you move to a different city, then you will have up to above 65% of prenatal detection. So depending where you are and who is scanning you, you will be able to pick up more or less detections, anomalies. So that was the reason why the guidelines were created. So as I say, I will be using mainly these two, the one from the International Society of Ultrasound, the 2013 one, and the one from the AIUM, 2013 and 2019. So the idea of the guidelines is to have standard views, standardize the practice, so to improve the prenatal detections and reduce the regional variation. And this is also because there are different backgrounds of whoever is scanning. So we have the pediatric cardiologists, the fetal medical specialists, and the sonographers. Okay, so what is the difference between a basic heart scan and a fetal echocardiogram? And I think there is a lot of overlapping. Basic heart scan is done as part of the routine anomaly scan for the low-risk group, whereas the fetal cardiology, fetal echocardiogram, will be for the high-risk group, and this can be done for people who have been referred with a suspected anomaly, or whoever, as we just discussed, is in the high-risk group. Okay, so what do we do? What is included? As I always say, we do everything. So we look at everything in detail, and we try to do it 2D, grayscale, and also in color. And we do interrogation of the valves and assessment of the cardiac rhythm and function. And we measure, if we can, everything. And particularly when the things are abnormal, you want to see if there is progression during the pregnancy. So you want to measure the size of for example, the aortic valve or the pulmonary valve. The other thing is the fetal echocardiogram will include the extended views that I will explain later on. So technical factors, so the babies move, and they move a lot. And we have issues such as a high maternal BMI and the fetal position that can limit the images we're getting. So we will have to try to optimize and maintain a high frame rate. And to do that, we need to narrow the image depth and the sector width. The better image resolution we have, the more we can detect subtle defects. We use the higher frequency probes in the mid-trimester, and then we will use the lower frequency probes late in pregnancy or in moms with a high BMI. Okay, so let's start with this segmental sequential analysis. So we want to go through what is connected, all the segments, how are they connected? So you want to see the great veins, see where are they connecting, then the atrium, so that's the veno-atrial connection, then what atrium is connected to what ventricle, so that's the atrioventricular connection, and it can be concordant or discordant. And the ventricles then look which arteries are coming from each ventricle. So that will be, are they concordant, are they discordant? So for the ones, I understand there is a mixed audience. So for whoever is not an obstetrician and is scanning a fetus for the first time, I think the most challenging thing is to try to understand how the baby is lying. So establishing the fetal lie can be quite challenging for whoever hasn't done it before. I come from a pediatric cardiology background, so I wasn't used to have babies upside down. So this takes some time getting used to. Also, the baby's moving around and doing 360 loops in the middle of the scan. So the easiest way that I find is just establish your transfer view, and then when you know where is then you sweep up and down, find the head of the baby, and then you can define your laterality. It helps also having the sagittal view to know if the baby is longitudinal or transverse. I train in the UK, and this is where we don't do the other approaches, but I know for people trained in other places, they do sometimes have the Cordes technique when they put the baby in a sagittal position, the head of the baby on the right, and they rotate 90 degrees, and they have like this standard view. We don't do that in UK. I find it as an extra step, but it's whatever makes you, whatever you are sure where is the right and where is the left. So transfer views, so we will start, I will go through each of them. We'll start with the situs, laterality, and then we will sweep up, tilting the transducer up. 4-chamber view, left ventricular flow tract, right outflow tract, and then the 3-vessel and tracheal view. So abdominal situs. So here you want to see where is the stomach. So you know where is your right and your left. So in this one, we know the left is on the left of the screen and the right is on the right. So you have the stomach on the left. And then you will have, in a normal situs soleus, you will have the aorta will be posterior and towards the left, and the IVC will be anterior and towards the right. Okay? And then you should be able to trace a line in between and have one in each side. So this is the normal situs view, situs soleus. It's important if you see any abnormality to check, because this is a hint that there might be other problems associated in the heart. So if you are suspected, then just look carefully for everything else. So we have abnormal situs view. So the situs is the way the heart is connected. Well, it's the whole body, but we have for this particular, we're going to speak about the atrial situs. And we can have usual atrial situs, that is the right on the right and the left on the left, and the right will be this broad-based atrial appendage. So I don't know if you can see in here. It's kind of rounded. So this is the right atrial appendage. And the one on the left is kind of finger-like. It's not showing. Is there a pointer or how can I? Well, I'll point. So you see in the drawing of the, sorry, I went back. So in the drawing in the middle, you have the one on the right, is the usual one. So this round thing is the atrial appendage. The one that looks like a little pointy thing, a finger, is the left atrial appendage. So this is the usual one. Thank you. Let's see if nope. Try it and see. Okay. Anyway, the one on the left is the mirror image. So you can see they're inverted. So the left atrial appendage is on this side, and the right atrial appendage on the other side. And then this is just for comparisons. You have the situs normal, the normal situs soleus here, and you will have the situs inversus that is completely exactly the same, but just the other side. So the aorta will be on the right side, posterior, and the IVC will be anterior and towards the left. So that's situs soleus and situs inversus. And then you have two other types of atrial arrangements. So you have the right isomerism, where you have two right atrium with two right atrial appendages. So in this one, you have, as you can see in the drawing, so you will have the aorta is posterior and to the right, but the IVC is on the same side. So you put a line in the middle, they will be together on the same side, either the right or the left. Important because it can be associated with anomalous pulmonary venous drainage, bilateral disease, and other conditions such as spleen absent or malrotation of the bowel. Okay, now left atrial isomerism. So in this one you have two atriums, both look like a left atrial appendage, so they are both like finger-like. And in this one, you don't have, because there are two left atriums, you don't have, the IVC is not connecting towards the left. So it's interrupted, and there is a azygos continuation. So when you look at the situs, you don't see the IVC. What you have is an azygos vein, that is the one that is continuing the IVC interruption, and is behind the aorta. So, okay, so you can see it here in the picture, and then when you look in your sagittal view, you will have this vessel behind the aorta. So that's the azygos. So that will give you a hint. Even if you miss it in the situs view, when you look at the sagittal, you'll see this behind. Why is this not? Thank you. From transverse views, we're following these two vessels, and you can see how the azygos is behind the aorta. Let's try. Okay, let's kind of make work the pointer. Let's just carry on. Okay, so let's move on. So we tilt toward the head, and then we are going now to the four-chamber view. Okay, so this is the transfer view across the ribs, the plane of the ribs. So you should have one single rib around, and I will just go into more detail in the next. So what we want to see in this view? So we want to see where is the left, where is the right, where is the stomach? Is the stomach on the left? Is the heart on the left? How big is the heart? Does it occupy 1/3 of the thoracic area? And for that, you can do the cardiothoracic ratio. That is usually normal between 0.33 and 0.55. So the majority of the heart should be in the left chest. And you should always do your axis, because again, this gives you a hint if there might be some cardiac anomalies. So you do a line from the spine, just all the way up, and then you put a line in the ventricular septum. So this angle should be 45 degrees. Let's try this again. Anything more than that will be a left axis deviation. And again, this is associated with cardiac anomalies. You want to check that there are 4 chambers present, that there is a regular rhythm, and no pericardial insufficiency. Okay, so this is an example of left axis deviation. So you put your line, do the line from the ventricular septum, and you can see this is almost perpendicular. So this is a left axis deviation in a tetralogy in this patient. It's associated with conotruncal anomalies, Epstein's anomaly, and pulmonary stenosis, convertation of the aorta. You want to see where is the heart in the chest. So is it levocardia? Is there dextrocardia? And I just want to mention, so you have to see where the apex is pointing. So if the apex is pointing towards the left, usually, it's probably because something is pushing it, has pushed the heart towards the other side. So we call that dextroposition. Either a congenital diaphragmatic hernia or a CCAM. If the apex is pointing towards the right, then it's a true dextrocardia. This is an example of a dextrocardia. Here. Okay, and then it could be mesocardia. And then ectopia cordis, we clearly don't see that often. Sorry. Okay, this is an example of cardiomegaly. Okay, wow. Let's look at the 4-chamber view. So you want to see 4 chambers. There should be approximately the same size, the atrium and the ventricles. The foramen ovale should be flapping onto the left atrium, and they should be right to left shown at that level. You want to see the crux of the heart. So that is just the part close to the valves. It should be present. And in 2D, you can see here some of the pulmonary veins starting to come back to the left atrium, at the back of the left atrium. Okay, so you want to check that there's no wall hypertrophy, and you want to determine which one is, so you know which ones are your atriums, because you have the sides view. Now you want to check which ones are your ventricles. So for that, you have to look at the moderator band. So the one on the right, you can see the moderator band is trabeculated, and then the tricuspid valve will be apical. There will be an offsetting of the valve, and it will be more apically displayed. So the insertion of the valve will be a bit more down than the one on the left. Okay. Okay, you want to see that the aortic, the mitral valve and tricuspid valve, they open freely. They come and go during systole and diastole. Okay, color. So ideally, we should be using color. And this is because it gives us a lot more of information. You can see the flow going through the mitral and the tricuspid valve, but you can also see it should be going from the atrium to the ventricle. Everything that comes back up will be regurgitation, and that will be abnormal. And you won't be able to see this unless you put color on. Also, will give you idea if there is any defects in the ventricular septum, help you determine the flow at the level of the foramen valve, and also helps you with the pulmonary arteries. As a tip, if you have a pericardial effusion and you put color flow, you will see it moving. So if you are suspecting and you're not sure, is this the wall of the ventricle or is it an effusion, put the color flow and you will see it moving. Pulmonary veins, so ideally we should see them both in 2D and in color flow. And the reason for that is that to show them you need to decrease your scale, so you have to go to a Nyquist around 30. And the reason to show them in both, not only on color, is because sometimes it may look like they are connecting, like if you see in the picture on the upper right, they look on color like they are draining towards the left, but when you look on 2D, they are actually not joining. This is what is called the Twix sign. So very important to show them on both. And then you can Doppler them to have more information and to confirm they are there. They are there. Okay, so again, it's screening the ventricular septum. So it has depth, so you have to go up and down. Color flow, it will help you to show VSDs that are less than 2 millimeters. You won't be able to see them unless you put the color flow. For defects that are more than 2 millimeters, then you will see them. They will have echogenic borders. In this on the right, you can see where there's a small VSD that will probably close spontaneously before this baby is born. So pulse wave Doppler. So we'll interrogate both valves. It helps you to see the flow, that they're actually working well, that there is a flow going through. Okay. This is some of the defects that will have an abnormal four-chamber view. So on this, we're very good. We're all very good at picking up four-chamber disease because they are easy to spot. There's some missing. The left ventricle is small, the right ventricle is small. Okay, so this one. So whoever wants to shout, what is this on the left? This is the left of the heart. This is the right. So you have, if you see, you don't see much of a left ventricle. You see a big right-sided ventricle, but you don't see much of a left ventricle. So this is a hypoplastic left heart. And on the right side of the screen, so it's the contrary. You have your left ventricle on this side, and the one on the right looks quite small. So it's a pulmonary atresia. Okay, this one. So this is when our segmental sequential analysis comes into play. So what is the right ventricle, what is the left ventricle? So we know that this is the left, and we know this is the left ventricle on this side. And then when you are connecting it, you see that the one in the left is actually quite trabeculated, has a moderated band, and the offsetting of the valve is more apical. So this is the right ventricle. So the atrium is connected, left atrium is connected to the right atrium. The left atrium is connecting to, the right atrium is connecting to the left atrium. So this is a discordance, so AV discordance in a patient with a CCTGA. SWIPs, and I think I will mention this, it does give us a lot of information. It gives you the dynamic, it gives us the depth of the defect. So we do like to review them, to record them. Okay, now moving into the left ventricular outflow tract. So what can we see in here? So we see the aorta arising from the left ventricle. We should check the caliber. We should see that there is continuity between the interventricular septum and the anterior wall of the aorta, and then there should be also continuity between the mitral leaflet and the posterior wall of the aorta. And again, the aortic valve should be very thin, should be thickened, and should be moving freely. And the right ventricular outflow tract view, then you will see the pulmonary artery arising from the right ventricle, and it should arise only from the right ventricle. And then you will check the caliber of the pulmonary artery that should be bigger than the aorta. Okay, so these ones, I will say, the abnormal outflow tracts is still a work in process. We are getting better at picking up conditions that are that have an abnormal outflow tract, but we're still missing a lot. Why? Sorry, maybe. Okay, it doesn't want to play. Okay, well, so things like transposition of the great arteries, tetralogy of Fallot, they will have a normal four-chamber view, and you will only be able to diagnose it when you look carefully at the outflow tracts. Okay. I'm just showing you, this is an outflow tract view, the pulmonary artery with the branching, and just to show the detail of things we can see, there is an aortopulmonary window in this view. So there is a little shown in between of them. This is kind of an incidental finding more than something you will routinely see. So abnormal outflow tracts, so this is an aorta that is overriding the ventricle. And you can see the color flow and the Doppler in the 2D, and the other one is similar. So this is a tetralogy of Fallot patient. Okay, this one, when you look at the aortic valve, you'll see it looks very thickened and dysplastic. So this is an aortic stenosis. And when you put color flow, so it gives you the information. You see, you have alleviation of the flow at the level of the stenosis, and you have also some regurgitation. So some blood is coming back. And then you can Doppler, and you will have a high velocity. And now there is published the normal values, and you can plot your findings of biometry or the Doppler against the gestational age of the baby, and then see is this normal, is this abnormal. Okay, and then for crossing of when you are sweeping up, you want to see like here, you want to see the vessels crossing. So you see first the aorta, and then the pulmonary artery. So that's the normal crossing. On this one, on the right side of the screen, they are both parallel. So this baby has TGA. There is no crossing of the great vessels. Okay, and then when the transducer higher up, tilting towards the head, then you have the three-vessel view and the three-vessel tracheal view. And there are views that were recently introduced, and people are still getting used to, but they give us lots of information, and very critical information, because these are the ones who decide if a patient has a dog-dependent lesion. So from the left to the right, you will have pulmonary artery, aorta, SVC. And they will be, if you do an oblique line, they will be in this direction. And in the three-vessel tracheal view, they're very similar, but then you do see the trachea that will help you to decide on the sideness of the arch. Okay? So you have to see three vessels. You have to check the size of the vessels. So the pulmonary should be bigger than the aorta, and the aorta should be bigger than the SVC. The arrangement of the vessels, so if the aorta is on the left side of the trachea, like in the clip over there, then you will see a V shape. The direction of the flow, so they should be both going in the same direction, and not like here, that you can see one is going, it has some reverse flow. So this one is giving you a hint that this is a dog-dependent lesion. And then dog-dependent lesions like coarctation of the aorta, critical aortic stenosis, critical pulmonary stenosis, pulmonary atresia, hypoplastic left heart, TGA, and interrupted aortic arch. This is an example of coarctation. So you have ventricular disproportion, and then when you see at the three-vessel view, you can see the aortic arch is small in comparison to the pulmonary artery duct. Again, another abnormal three-vessel view. So instead of having three vessels, you only have two. So this is a TGA. Okay, anyone want to comment on this one? Yeah, so it's a critical aortic stenosis. There is reverse flow. Okay, and then U shape. So we are not seeing the normal V shape, and this is because there is a right aortic arch. So it's on the other side of the trachea. The trachea is in the middle, and then you get this U shape. And sometimes we can even diagnose double aortic arch. So in this one over here, you can see the duct, the right aortic arch, and then that will give you your U shape. But then you can see also this vessel coming down. That is the left. There is the left arch, and it's a double aortic arch with a dominant right arch. Okay, this is a sweep with lots of abnormalities. Yes. So we have dextrocardia, we have an inlet VSD, we have the right ventricle is on the left side of the heart, and then you have your vessels are transposed with the aorta and then the pulmonary artery being hypoplastic. So this is just to show you the constellation of things we deal with and why is it important to go segment by segment so you get all the information. Sagittal views, very important for the arch, just to remind you to sweep so you can see both arches, the ductal arch and the aortic arch. And the low and high short axis, they are very helpful, for example, to see VSDs. This is an example here. You can see there is the aorta is in the middle, and there is a tricuspid aortic discontinuity. So there is missing a bit, and that's where the VSD is there. And the next one is normal. So you put color also to help you see if there's any VSDs. There's no VSDs. Fetal rhythm assessment, I will just mention we do it. There is a talk later on fetal arrhythmias. I'm not going to. We do it, and then different ways of measuring your rhythm. And just to finalize, so I just want to say we do look at a lot of things. We do pick up a lot of things, but there are things we cannot pick up, such as small VSDs or ASDs, the partial anomalous pulmonary venous connections, minor valve abnormalities, and coronary artery abnormalities. Also that there is a progression of the disease. Sometimes you may scan at mid-trimester and just have subtle changes. And there is a progression, and at the end of the pregnancy, things have evolved. And the same with arrhythmias. They can appear the third trimester. And it depends a lot in the fetal lie and the way, and the maternal habitus, the maternal BMI. Okay, thank you.